You want to go first? Okay, I'll invite Dr. Ramamurthy, who's going to take us through the challenging situation of white intumescent cataracts, how we handle those cases. I think that needs to be seen and understand. If you pick out even 1 or 2 points, you all are doing good phacosurgeries, but there's always tip and tricks from one person that should be always taken by the people sitting here. Dr. D. Ramamurthy, who has been a ex-past president of AIOS, who is one of the most versatile surgeon I've seen in my life, and one of the most important person to deliver talks in all areas, right from the cataract, refractive. Dr. D. Ramamurthy, sir.
Thank you so much. It's truly an honor to be a part of your course, and thanks for the repeat invitation. I'll be taking you through intumescent cataracts. What are the simple points that needs to be kept in mind? This is basically a very basic handling of the whole problem. So many of you, what I say might resonate with what you do in your day-to-day practice. One of the vital points that we need to remember is that we have to keep the anterior capsular surface flat. And the problem with intumescent cataracts is that the intralenticular pressure is greater than the intraocular pressure, intracameral pressure. Because of this, there's a hydrostatic pressure for the capsule to run off to the periphery. So it's like keeping the slope flat. And you do a simple small nick, usually just curve it out a bit and don't keep it absolutely straight so that there's a greater tendency to run out. And then use a simple cannula to aspirate whatever cortical, the floppy cortical matter that is there. This can be done a multiple number of times. Usually you aim at a slightly smaller rexus than what you would normally want, and because there's invariably a little bit of extension. And it's a good idea to, of course, in white cataracts like this, you would invariably go ahead and stain the capsules, but even otherwise, it's a good idea to stain because that also enhances reduces the elasticity of these capsules. As you can see, you can use either the capsular rexus, the bent needle through the side port. Please watch over here. I've been taking it very slowly, but I'm losing, there is a little loss of viscoelastic over here. I think it's almost done. But at this point, viscoelastic should have been injected. And since that has not been done, there is a runaway. And this is something you need to come that go back, refill, ideally with cohesive viscoelastics, otherwise with something like a dispersive viscoelastic like a viscoat, which will keep the chamber formed right through. The basic premise, the basic principle, whatever is going to follow is the idea of keeping the anterior capsule flat so that the passage of your capsular rexus is quite smooth and controlled. So let's look at a pediatric cataract situation. Obviously, again, the flocculant material inside and absolutely white cataract. Here, invariably, even if it's a fairly clear capsule, I'd go ahead and stain, essentially to make the capsule less elastic. As I already said, you please look at the maneuver that I'm doing, that is catching hold with the capsular rexus forceps. It's not only centripetal, but also I'm dragging the capsule towards the center, towards the apex of the cornea. And this is the kind of, and look at the number of times I'm leaving, grasping and re-grasping. It has to go in a very methodical manner. In these cases, once you get a good capsular rexus, 80% of your surgery is over. So the trick is to get a well-centered 5 to 5.5 millimeter rexus. It's doable. You just have to exercise enough amount of caution, enough amount of basic principles that you need to follow, and patience. So what you see over here, that capsular rexus is quite complete. Obviously, it's a I'm not going to be dealing too much with evacuation of the lens matter because that's something very, very simple. This is what you get at the end of the day, and if necessary, a posterior rexus can also be done. Let's go ahead. Here I want to just demonstrate a brand little maneuver. When there is a tendency for the capsular rexus to run off, what exactly you do? You can see that I inject a certain little amount of xylocaine to make the chamber quite tense, also stain the capsule, and then we go ahead and inject a viscoelastic, ideally cohesive viscoelastic, and then go through the side port. I think not distorting the central incision and going through the side port is a good idea. And you can see the caution with which I'm constantly trying to keep the anterior chamber well inflated. That's the initial nick that I made. And you see it's not a straight out nick, but it's slightly curved. Once you curve the nick, there is a lesser tendency for the rexus to run off to the periphery. And you can see that in a very gradual manner I'm progressing. And whenever you feel there's intralenticular pressure is high, you can go ahead and aspirate a little amount of cortex. And at this phase, I go ahead and do this. You can see this some escape of viscoelastic. Obviously, I'm going to refill the chamber with viscoelastic. And it's important that when you inject the viscoelastic, you go on top of the rexus. This is the point I want you to notice. And here, whenever it's not going in a centripetal fashion, but it's running out to the periphery, that's when you need to stop. You see over here, it's not going in this direction, but it's tending to go in this direction towards the periphery. And here it's important that you bring the rexus back. So what Brian Little of England has described and what many of us follow is to put the flap back onto the lens surface and drag it along the direction in which you are making the rexus and subsequently drag it inwards. This will be a quick maneuver, but this is what is basically done. In the sense you put the flap back, then drag it down inside and then inwards, and that helps you to restore the configuration of the rexus. That's what you'll see it happening now. The whole surgery is being done under topical anesthesia. I'm fixing the globe with a Sinskey hook, and that's holding the rexus margin, dragging it down and then back again, then you are back on track. Of course, there's a bit of a overlap of the rexus onto the lens. That's not going to happen in optics. That's not going to happen in this case, but that's a small price to pay. It's best avoided, but in case there's a tendency to run off, this is a simple maneuver that you can keep in mind. It always works. The other thing is to, as I already mentioned in pediatric cataract, whenever you're using the capsular rexus forceps to drag towards the centrally as well as towards the apex of the cornea, which gives you better control. The other way to handle this would be to do a double rexus, obviously quite flocculant material. So getting a smaller rexus in place initially, and which allows you to evacuate lens material quite adequately, both in front of the lens and behind the lens. Remember, when you are dealing with a intumescent cataract like this, the material is not only present in front of the nucleus, also behind the nucleus. So this maneuver of creating a small rexus and subsequently washing out the cortical matter essentially is the best way to reduce the amount of lens material that is there, because it washes out the cortical matter that's there behind the nucleus also. That's a smaller rexus being done. Or it's possible to even complete your phacoemulsification through this, but it's not a good idea because you could end up cutting the rexus. So this is when we are making the main port itself, and then subsequently you can safely go ahead and do adequate amount of hydrodissection. And you see, it's not essentially to mobilize the nucleus, but it's to allow all that cortical matter to flow out. Once it's done and you feel the capsular rexus is quite flat, you have to do, basically this nick has to be again in a tangential direction and not radially, because that itself would make the rexus run off. Then gradually you can go ahead and extend the rexus, if necessary a full circle or semicircle, depending on the size that you need. And then, of course, as I already mentioned, these cataracts are either fluid or quite brittle. So essentially, these intumescent cataracts, as far as the nucleus removal is concerned, is not really a challenge. All of us would be quite comfortable doing this. And it just takes a minute or so to complete this procedure. I'm not really going to comment much on that. A phaco chop, what will you do? But in case you want to do a stop and chop, that will also work quite equally well. Removal of the cortex and subsequently intraocular lens placement. Again, in case you feel the rexus is not quite adequate, even in this step, you can go ahead and extend the rexus so that at the end of the day, you have an adequate coverage of the optics of the lens, but at the same time, it's not too small a rexus that you are having. You can see these two small bumps over here, because these are the one over here and one over here, because these are the two places where the rexus has been cut in two different situations. It's actually not a double rexus, but a triple rexus that has been done. One before the nucleus removal, another after the placement of the intraocular lens. I think the greatest advantage of a laser refractive cataract surgery suit is the ability to perform a rexus in situations like this. Please notice this flocculant material over here, and it's obviously a capsule which is bulging forward. And once you dock appropriately, almost always you get a free-floating rexus like this. We stain these capsules more to see where exactly the capsule is floating around. As you can see over here, you will find that it's completely free and lying over here. If you have access to this kind of an equipment, obviously that's a great way to go. But occasionally, even in spite of having access to this equipment, things do not go right. You can see again the lens bulging forward. I thought everything was under control, but you can see when I take the patient under the microscope stain, it's an absolutely disrupted capsule that we have. So sometimes you are faced with this kind of a situation, but then it's possible to manage this. This patient actually had received a multifocal intraocular lens in the other eye, and because there are tags of anterior capsule that are available, I was able to complete the surgery. Last, a quick video, just to show you that a tag over here that has to be recognized, and the way we have gone around it so as to include it. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. I think it was wonderful videos to be, being such a good teaching points in those videos, and the points you have highlighted was really important. But sometimes you do have, tears which is very uncontrollable, and things become very, very difficult. Is there any way where situations where we can't implant the in the bag lenses in these white cataracts, where we should avoid putting in the bag lenses?
Yeah, actually, I think if it's absolutely disrupted, and if you feel that the lens is going to be one side is going to be behind the capsule and one side is going to be anteriorly, I would rather shift to a 3-piece lens and place the lens on the capsule. So in these cases, I would avoid using a single-piece intraocular lens. Of course, if you have a rexis wrapping around and if your PCR is there, that's a completely different scenario where you need to deal with it.
Sometimes, white cataracts, we can't access the posterior capsule. So is there some guidelines where we avoid doing a hydro procedure in these cases so that we take care of a posterior capsular weakness? Sometimes these patients can have a posterior polar cataract also.
I think that's a very good idea, and most often these white cataracts don't need hydrodissection. Actually, they can be easily rotated even without a hydrodissection. So most often I avoid doing it, except in that double rexis kind of situation where more to evacuate lens material that you are doing it.
Thank you. Yeah, Abhay?
You showed it very well, the signs on the sonography of the white cataract. But UBM and B-scan, as you already mentioned, both of you, is very important in a white cataract, particularly younger person.
I think that's an inbuilt advantage with the OCT when you're doing an LRCS, because that automatically shows you whether there's a posterior plaque over there.